Hello guys, welcome back to Medico DIY, and today in this video we'll be talking about cerebrovascular disease aka stroke. Before jumping into the topic, let's talk about the mnemonic fast. The most common symptom of stroke is facial weakness. F stands for facial weakness, A stands for arm weakness, S speech problems, and time to call the ambulance. If we see any person who have facial weakness, and when we tell the person to raise the arms, and we can see that there can be arm weakness, and when we tell the person to speak, and if there is speech problems, then these are most common likely to be the symptoms of stroke, and hence it is time to call the ambulance, or it is time to take the patient to the hospital as soon as possible. These are the most common symptoms of stroke. Now let's start the topic. Cerebrovascular disease, it is the most common cause of physical disability, and it is the third most common cause of death after cancer and ischemic heart disease. Stroke, it is the most common clinical manifestation of cerebrovascular disease. Stroke, it refers to the sudden onset of focal neurological deficit due to vascular cause, which results in hemiplegia with or without other features, and here the symptoms last for more than 24 hours. If the symptoms last for less than 24 hours, it is called as TIA, that is transient ischemic attack. Now let's talk about the classification of stroke. Stroke, it is widely divided into two types, that is arterial stroke and venous stroke. As we can see that arterial stroke, it constitutes about 99% of the stroke, and venous stroke, it constitutes about less than 1% of the stroke. So the arterial stroke is more common than the venous stroke. Talking about the venous stroke, it is caused due to an infarct, cerebral venous thrombosis. Now let's jump into the arterial stroke. The arterial stroke is further divided into ischemic or infarct stroke, which constitutes about 85%, and hemorrhagic stroke, which constitutes about 15%. Further, the ischemic infarct is divided into anterior carotid circulation stroke and posterior vertebrobasilar circulation stroke. The posterior vertebrobasilar circulation stroke, it includes posterior circulation stroke, which constitutes about 20%. Talking about the anterior carotid circulation, it constitutes about three types of stroke, that is total anterior circulation stroke, which constitutes about 15%, partial anterior circulation stroke, which constitutes about 30%, and lacunar stroke, which constitutes about 20%. Now let's talk about the hemorrhagic stroke. The hemorrhagic stroke, it is further divided into the one which involves the brain parenchyma, that is 10%, and the one which involves the subarachnoid space, which is 5%. The one which involves the subarachnoid space, it is called as subarachnoid hemorrhage, which constitutes about 5%, and the one which involves the brain parenchyma, it is called as intracerebral hemorrhage, which constitutes about 10%. This was the overall classification of the stroke. Now let's talk about the risk factors of stroke. The risk factors of stroke is divided into the modifiable risk factors and the non-modifiable risk factors. In the modifiable risk factors, it includes blood pressure, cigarette smoking, alcohol intake, the intake of estrogen-containing drugs like oral contraceptive pills and hormone replacement therapies, and the heart diseases like atrial fibrillation, congestive cardiac failure, and the infective endocarditis. There are some other modifiable risk factors, that is polycythemia, diabetes mellitus, and dyslipidemia. Now let's talk about the non-modifiable risk factors. The non-modifiable risk factors, it includes age, and the chances increases with the increasing age. In the sex, it is more common in male than females. In the race, it is more common in the Afro-Caribbean as compared to Asian, and it is more common in Asian as compared to the Europeans. The previous vascular event like myocardial infarction, peripheral vascular disease, and stroke itself. Hereditary, sickle cell disease, and high fibrosis. Now let's talk about the etiology of stroke. The etiology of stroke is divided into cerebral infarction and intracerebral hemorrhage. In cerebral infarction, the etiology is thromboembolic diseases secondary to atherosclerosis, especially in the carotid artery or aortic arch. Embolism from the heart or in the internal carotid artery, aorta, or it can be paradoxical. In the heart, it is most commonly from atrial fibrillation, dilated cardiomyopathy, myocardial ischemia, mitral stenosis, and valvular diseases. In the paradoxical embolism, the emboli, it is present in the peripheral veins, which moves through the heart, and in the heart, it moves through the right heart to the left heart through a septal defect, most commonly an atrial septal defect, and it reaches into the systemic circulation, that is brain. Hence, it is called as paradoxical. It can also be due to thrombosis in situ, and in thrombosis in situ, it is caused by intrinsic diseases by small perforating vessels like the lenticulostriate arteries, causing the lacunar infarctions, and rarely there can be vasculitis and endocarditis. In cerebral infarction, radiologically, we can see that there is a central area which is called as infarct core, and the infarct core, it refers to the dead brain tissue, which cannot be saved even if the blood circulation is restored, while the area surrounding the infarct core is the ischemic penumbra, and this is the tissue which can be saved if the blood supply is restored at the time. Now, talking about intracerebral hemorrhage, it constitutes about 10% of the acute stroke, and it occurs when the blood vessel ruptures into the brain parenchyma, including the subarachnoid hemorrhage. The risk factors for intracerebral hemorrhage is complex small vessel diseases with disruption of the vessel wall, myeloid angiopathy, impaired blood clotting, and vascular anomaly like atriovenous malformations and cavernous hemangioma. Now let's talk about the clinical features. In stroke, it presents with rapid onset of focal neurological deficit of the brain function of an identifiable area of the brain. It is negative in character, that is, there is abrupt loss of function without positive features like no abnormal body movements. There can be weakness of the face, limbs, there can be speech disturbances, and there can be unilateral motor deficit, aphasia, neglect, and visual field defects. If the brainstem or cerebellum is involved, then the patient may present with ataxia, diplopia, vertigo, with or without bilateral weakness. If there is large volume lesion, then there will be reduced conscious level. And if there is intracerebral hemorrhage, the patient may present with headache, vomiting at the onset of focal deficit. Talking about transient ischemic attack, here the symptoms of the stroke last for less than 24 hours or resolve within 24 hours. Then it is known as TIA or transient ischemic attack. But if it crosses more than 24 hours, then it is called as stroke. For investigation, various investigations can be done like neuroimaging, vascular imaging, blood test, lumbar puncture, and cardiovascular investigations. In stroke, cardiovascular investigation plays an important role because the most of the embolism, they arise from the heart, hence the cardiovascular investigation must be done. Now let's talk about neuroimaging. In the neuroimaging, it includes non-contrast CT scan, magnetic resonance imaging, CT angiography, and CT perfusion. NCCT, that is non-contrast CT scan, it plays an important role to differentiate between ischemic and hemorrhagic stroke. MRI, it is the most sensitive imaging study. Talking about vascular imaging, it includes USG and MRA, that is magnetic resonance angiography. The blood test is also must, which includes complete blood count, blood glucose level, lipid profile, ESR, ANCA, and genetic testing for CADASIL. The CADASIL, it stands for cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. Lumbar puncture plays an important role for diagnosing subarachnoid hemorrhage. And the cardiovascular investigation, it includes ECG and echocardiography. Talking about the treatment is divided into three types, that is supportive treatment, specific treatment, and rehabilitative treatment. Now let's talk about supportive treatment. Talking about the airway, bedside examination can be done, and the patient is kept nil per oral if the swallowing is unsafe or aspiration occurs. In breathing, we need to check the respiratory rate and the oxygen saturation and give the oxygen if the saturation is less than 95%. For circulation, we should check the peripheral perfusion, pulse, and blood pressure, and treat the abnormalities with fluid replacement, antiarrhythmic inotropic drugs. The patient should be given fluids if the patient is dehydrated. The nutrition is maintained by giving supplements, nutritional supplements. And if the patient has dysphagia lasting for more than 48 hours, then NG tube is placed for feeding. The blood pressure should be maintained at an appropriate level. Blood glucose level should be checked, and it should be treated if the blood glucose level is more than 200 milligram per deciliter by either giving insulin or glucose or potassium infusion. And the patient blood glucose level should be monitored closely to avoid hypoglycemia. If the patient has pyrexia, then the cause should be investigated properly, and the temperature should be controlled with antipyretics. For the pressure areas, reduce the risk of skin breakdown by treating the infections. By treating the infection, maintain the nutrition. And turn the immobile patients regularly. In incontinence, we need to check the patient for any constipation or urinary retention and treat appropriately. We should avoid urinary catheterization unless the patient is in acute urinary retention or incontinence is threatening the pressure areas. And mobilization. The patient should avoid the bed rest. Now, talking about the specific treatment, it is divided into intravenous thrombolysis and antithrombotic treatment. If the patient presents within 3 hours of onset, then intravenous thrombolysis is done, which reduces the disability and mortality from ischemic stroke. The drug is given at the rate of 0.9 mg per kg IV as 10% of the total dose as bolus, and the remaining as in continuous IV infusion over 60 minutes. No other antithrombotic treatment are given for 24 hours, and avoid urinary catheterization for 2 hours. If the patient presents after 3 hours of the onset of stroke, then antithrombotic treatment is done. The patient is given aspirin, or if the patient cannot take aspirin, then clopidogrel is given. And if the patient cannot take the clopidogrel, then ticlopidine is given. The alternative treatment is endovascular mechanical thrombectomy. The statins are given to stabilize the plaque in case of atherosclerosis, and neuroprotection is done by hypothermia. Hypothermia, it is the most powerful neuroprotection. Talking about rehabilitation, it includes the early physical, occupational, and speech therapy. Hope you like this video. Do share it with your friends, and stay tuned for more videos. Thank you.